Hello, doctors. Today, let's talk about an important topic that is about the thyroid cancers. This topic is important in the pathology section, in the medicine section, as well as in the surgery section. In this video, we'll talk about some pathological findings, clinical features, and the surgical treatment for thyroid cancers. Mainly, I'll take the discussion in a way that you can easily answer the questions when asked in the exam. Usually, thyroid cancer questions are asked in the case format. So, at last, I will tell you some buzzwords by which you can immediately find out the type of cancer they are asking. So, let's go into the topic. Now, when we talk about thyroid cancers, generally there are four varieties: the papillary, follicular, medullary, and anaplastic. Now, each has different characters, and let's see about it. When you talk about the papillary cancer of the thyroid, pathologically it has some classical clinical findings. Classical findings like orphan nuclei. This is pathognomonic for this papillary cancer of the thyroid. You can also find samoma bodies in papillary cancer of the thyroid. It is also found in some other papillary cancers, for example, in the ovaries. And usually, the papillary carcinoma of the thyroid is of multifocal in origin. Now, let's see the clinical features of this cancer. Generally, in the population, papillary carcinoma of the thyroid is the most common cancer of the thyroid. It is seen usually in the middle-aged female like 35 to 45s, and it is also seen in patients who had history of radiation to the neck or to the chest or to the head. For example, people would have had CT scans many times for their chest, and people also who had previously thyroglossal cyst can develop this cancer. Usually, this cancer has excellent prognosis, even though it has common metastasis to the cervical lymph nodes. This cancer, among the all, has the best prognosis. Now, for the treatment, whenever the cancer size is less than 1 centimeter, you can just remove the lobe. For example, if there is a 0.5 centimeter mass in the right lobe of the thyroid, and you do FNAC and confirm it to be papillary cancer, you can just do a right lobectomy. But if the cancer is more than 1 centimeter or it's in the middle, you will have to do near total or total thyroidectomy. Now, coming to the next type, the second most common type, follicular carcinoma of the thyroid. Pathologically, it is solitary and it is encapsulated. Usually, it has vascular and the encapsulated thing, it has capsular invasion. With FNAC biopsy, you can differentiate a follicular carcinoma from follicular adenoma, because until or otherwise uh, proven that follicular cancer has invaded into the vascular or it has invaded the capsule, it is said to be a follicular adenoma. Only when it invades the capsule or the blood vessels, it is considered to be follicular carcinoma. This thing cannot be differentiated using a FNAC, that is fine needle aspiration cytology. So, FNAC is not reliable for follicular cancers. Usually, these cancers are seen in iodine deficient areas. Previously, in the mountain regions, we would have seen this, but nowadays it's not that common. And the classical patient is a 50-year-old female. Unlike the papillary carcinoma, in the follicular carcinoma, lymph node metastasis is uncommon. Follicular carcinoma is also seen in patients who have a history of goiter. Just now I said that it is seen in iodine deficient areas. People who are iodine deficient tend to develop goiter. This goiter can cause follicular carcinoma. That's how it is related. As I said before, FNAC cannot differentiate follicular adenoma from follicular carcinoma. Now to treat this, whenever it is a you first take the patient to the operation theater, and during the surgery you take a biopsy of the tissue and send it to pathology department. When you find out that it is a follicular adenoma, just removing the lobe of which the tumor arised is enough. But when you confirm it to be a follicular carcinoma, a total thyroidectomy would be necessary. So that's how we go with the follicular carcinoma. Then the next type is medullary carcinoma. For the pathology sites, we can see that it usually arises from parafollicular C cells. Usually in the specimen slides, you would have seen the follicular cells. Just near to that is the parafollicular cell, or also called as the C cells. Medullary carcinoma of thyroid arises from parafollicular cells. In the slides, you can also see an amyloid stroma, that is deposition of proteins. Medullary carcinoma are mostly bilateral. It usually occurs in the both lobes. For the features, we know that the parafollicular cell produces calcitonin. So when a tumor arises from parafollicular cells, there will be elevated calcitonin or CEA levels. Medullary carcinoma is mostly associated with MEN syndrome, that is multiple endocrine neoplasia 2A or 2B, which also includes some other cancers like pituitary cancer or parathyroid cancer or pancreatic cancers. Due to this, we always do a CT or MRI so that we can exclude metastasis to liver and chest and also find if there are any other cancers. To treat these patients, we have to do a total thyroidectomy with bilateral central neck node dissection, because this cancer is easily metastasized to the nodes, central nodes, and also to other organs. And so in these cancers, family history plays a major role because of association with MEN syndromes. Then the last one, anaplastic carcinoma. It is usually seen with giant multinucleated cells. These cells are of many shapes and size. This cancer usually arises in old females, and it is a very aggressive tumor. Just you can diagnose that cancer today, and in 5 to 6 months the patient will be no more. It usually has direct spread to other organs or lymph node spread. Usually at the time of diagnosis, you would have also find metastasis to other organs or lymph nodes. And to treat this, most of the patients usually will be requiring just palliative care because they are beyond treatable. But if you find this cancers early, you can do a total thyroidectomy and neck node dissection plus chemoradiation. So these are some important points about the four major types of cancers of thyroid, and you should know all these points because you would get all except questions. And now for diagnosing or finding what the examiner is talking about or which cancer is he talking about, I'll tell you some buzzwords for each cancers. For example, when you see orphan ani nuclei or samoma bodies in the question, you should think about papillary thyroid carcinoma. When you see that FNAC was not enough to confirm the diagnosis or the cancer had vascular invasion, you should think about follicular thyroid carcinoma. When you see that the patient also had other tumors or family history of other tumors or an amyloid stroma, think about medullary thyroid carcinoma. When the examiner asks that says that it's an aggressive cancer and the patient died in few months after diagnosis, it must be an anaplastic thyroid carcinoma. Now for the question of the day, if you must have read about Hurthle cell carcinoma. If you know about it, just write it in the comment box about your knowledge about the Hurthle cell carcinoma. Thank you, doctors.